Good afternoon. I'd like to welcome you to this Medical Center Hour. Our program today is called Moral Distress in Health Professionals, a call for resilience or retreat? A question. I'm Marcia Day Childress from the Center for Biomedical Ethics and Humanities. I'm happy to welcome you all here for our Brody Medical Education lecture. Moral distress, defined as the physical and emotional stresses arising when one knows the morally correct response to a situation but can't act because of systemic constraints. Moral distress is well documented in the nursing literature, where it is linked to nurses' withdrawal from patient care and job attrition. But what about moral distress in other health professionals, including doctors and doctors in training? Studies done by Dr. Bonnie Miller and colleagues at Vanderbilt University School of Medicine have shown that moral distress indeed occurs throughout the process of medical education and training. While there seems to be some correlation, the exact relationship between moral distress and physician burnout remains unclear, although the two descriptors seem to spring from similar circumstances, namely problematic, deeply troubling interactions between exquisitely trained individuals in a complex, hierarchical, inequitably resourced health learning and healthcare system over which trainees and practitioners have little control. Moral distress in health practitioners and students challenges us all and creates certain moral obligations throughout the healthcare enterprise, from the classroom to the clinic to the boardroom. But do its negative consequences always render moral distress a negative phenomenon? Or might we see moral distress in health professionals as a barometer or a similar sort of significant signal telling an individual, an organization, or its leaders that something happening in the work to which all are devoted needs addressing? And if so, might our responses to moral distress episodes have positive, useful consequences for learners, practitioners, and the environments in which they study and work? In this Medical Center Hour, which is co-presented with the School of Medicine's Academy of Distinguished Educators, the Brody Medical Education Award Committee, and the Center for Biomedical Ethics and Humanities, we welcome Dr. Bonnie Miller, Senior Associate Dean for Health Sciences Education at the Vanderbilt University School of Medicine. She's seated on my immediate right. Dr. Miller, I'm happy to say, is the 2011 recipient of UVA's Brody Medical Education Award. She'll start our conversation on moral distress in health professionals with her remarks, and then responding to her presentation will be Ann Bowman, who is a fourth-year medical student, seated in the center there, whose work on the Medical Student Advocacy Committee has alerted her to the way that moral distress is very much a part of our medical students' experience. Following Ann Bowman is Baile Hamric, a professor in the School of Nursing, seated on my far right, whose scholarship on moral distress in practicing nurses and doctors is internationally recognized. We were talking about this program as Bonnie and the Anns. And we're hoping that after Bonnie and the Anns do their thing, we will have some time at the end of the hour for you to join in this conversation. And I'm happy to see that we have a thoroughly interprofessional audience, so I think we'll have time for a very rich discussion. So we'll start with Bonnie and then the Anns. Thank you. Welcome.
Well, thank you. Thank you very much.
Thank you very much for really giving me the tremendous honor of being here yesterday and today. I'd say this is very much a bidirectional learning experience. It's an honor to be here at UVA and to interact with all of you and to learn what you're doing. And it's certainly an honor to be the Brody Award winner, which I still can't get over, so thank you very much. I became interested in moral distress at Vanderbilt quite a few years ago, actually. I came to the Dean's office in 1999 with an interest really in how physicians become the people they are. Something I think there's some hidden psychologist in me, really pondered why people in more or less the same settings, clinical settings and training settings, would kind of turn out so differently. And this process of becoming, kind of a lifelong process of becoming, has always kind of fascinated me. We started meeting with students monthly, clinical students, 3rd and 4th years, and we called it Last Tuesdays, or Last Thursdays. Actually, it started out last Thursdays, and unfortunately a lot of exams were on last Fridays, and so we didn't get as many people coming to the Thursday evening sessions as we had hoped. We moved it to Tuesday, but we asked students just to come and bring their stories, things that either troubled them or really inspired them. We really didn't have a lot of criteria, just come and talk. And we tried to create a safe haven. We had a variety of faculty members from different domains in the medical center, including pastoral care and ethics, surgery and medicine. And I was talking about this yesterday, and we just wanted the student to faculty ratio to be greater than 1. And most of the time we were able to accomplish that. But we have a lot of faculty who are really interested in hearing the stories as well. And we did hear some stories that were really told with this sense of anguish, which was kind of puzzling to me at first, because students, the 3rd year students, really weren't responsible for what they were seeing on the wards. But despite that, they had this sense of shared responsibility. And I thought a lot about that. I think that's a good thing. I think students could probably pretty easily absolve themselves of that responsibility and say, it's not me. I feel badly about it, but for some reason they didn't. So let me see if I might turn down the lights a little bit. Great, thank you. Okay. This is a famous painting that I showed to our first year medical students the first day of orientation. Has anybody seen this painting? Okay, so it's called The Doctor, actually, and Marcia, you know where it hangs? Tate Museum in London, and it was painted by Sir Luke Fields around 1890. It was actually commissioned by Mr. Tate. And it's, I think, one of the more famous paintings of the physician. I think you see the child ill in probably a small home, the mother in the background, distressed, the father in the shadows, and the doctor just looking very intently at the child, completely focused on the child. And the close-up of the physician, I think, shows that intensity of the gaze, that he's thinking, and I can make up stories around this painting that he really wishes, I think, there was something that he could do. In 1890, for deathly ill child, we had germ theory, but not anything to do about it. And I think the sense of distress was a different kind of distress. I think it was not maybe moral distress, but just the distress that there wasn't much that could be done. So I think that a lot of our students, and certainly when I started medicine, I think this is who I hoped that I would become. This intent doctor that fought hard, tried to figure out the right thing to do, and used what would be at my disposal to help other people. But I think what our students see is not that scenario anymore. It's something more like this. The sick child here is a small baby. I think he was about 8 months old. It had tetralogy of Fallot, had a repair, it had some post-operative complications, and this is about 10 days after the operation, still on a ventilator, with a variety of tubes, chest tubes, Foley catheter, monitors telling us how the child is doing instead of the sort of doctor's intense stare, and the mother not anguished in the background, but right there in the room with the child. And the doctors then, of course, are here. Now, I will say these are wonderful physicians, and they really do care about their patients, but as you know, a lot of the discussion and the intensity doesn't happen in the room, it happens outside of the room. And we had some medical students standing around, and it's hidden from view in this shot, but one of the members of the team, of course, is the computer. And we refer to Dr. Verghese's, Abraham Verghese's notion of the eye patient, that the patient really exists in the computer and on the monitors, and sometimes you can run without actually seeing the child. But this is, I think, a strange world to be kind of enculturated to. And the enormity of that world, the complexity, and as opposed to the 1890s, when there wasn't a whole lot to do, I think now in 2011, sometimes there's too much to do. And knowing what's the right thing to do for whom and when then becomes a complicated issue that I think is at the bottom of a lot of our distress. We listen to these stories of trying to work themselves into this world and understand that world monthly for about 6 or 7 years, and felt that it was time to maybe study it in a little bit more detail. I was working with a graduate at the time, Catherine Wiggleton, who just graduated from medical school, had a young child herself, and wanted to take a year off between medical school and residency. She actually went through our pediatrics program at Vanderbilt and is now a faculty member, which is great to see. And she had a background, she had an MPH and a background in psychology, and knew a fair amount about survey development. So again, coming back to the definition of moral distress, we wanted to know the questions: how frequently did this actually occur in our medical students? And these were the questions: what's the incidence of moral distress in students and residents? What is the relationship to burnout, cynicism, and the erosion of ideals that have been documented in lots of papers about the process of medical education? What's the nature of the moral compact with patients in 21st century healthcare? Again, things are not the way they were when Flexner wrote his report in 1910, and when medical ethics or biomedical ethics had its birth sometime around the middle of the 20th century. All things changed. And then finally, what should we do? So this moral distress survey was originally 55 items, and it's long, and our students complain about it, and we've been able to narrow it down to 52 questions. It was piloted with fourth-year students in 2007. Measures both the frequency of events, and we have tried to anchor, it's a 1 to 4 Likert scale, and we try to anchor that so people have some kind of reproducibility. And intensity, how badly did you feel? Was it, it bothered me at the time, I didn't think about it again, it bothered me and it stayed with me for a week or a month, or it bothered me so much that when I think about it still, I get upset all over again. So we tried to, again, kind of anchor the ratings. And since 2007, we've administered it to third-year and fourth-year students and residents, actually since 2008. So we're accumulating a fair amount of data, and there's some things that we're seeing year after year. What we found was that actually moral distress did happen, or did occur, students on a fairly regular basis. This is the initial group of fourth-year students. That they experienced distress, but what was quite interesting was that there was a huge variability both in the frequency and the students' reaction to these distress episodes. And this, again, has really remains kind of fascinating to me, and I want to figure this out someday. That what are the people in the lower left-hand corner of the graph, that they don't see anything and don't feel anything, it looks like to me. And on the other hand, the people in the upper right-hand corner see a lot and react. There was this very strong relationship between frequency and intensity. And to a certain extent, some of that's additive, right? We created scores that were sort of summative scores for the measures of frequency and a summative score for the measure of distress. And some of the distress would be linked to frequency, although one of our hypotheses was that the more you witnessed these episodes, the more jaded you would become. So it could have been a very different line, that the more you saw, the less distress you experience. What we see is this relationship with the correlation coefficient of 0.66. And again, we've administered this survey many times now, and whether it's residents or students, or whether it was 2008 or 2010, we have seen basically the same line, the same distribution, the correlation coefficient of somewhere between 0.67 and 0.75. And it's, I think, telling us both something about individuals and their reactions to the complexity of the healthcare environment and the healthcare environment itself. But this has been a pretty constant finding. The kinds of things, the most frequent causes of distress are these kind of little things, the little things that kind of happen day after day and sort of can erode at you after a while. Bad-mouthing other teams. Does that happen here? Between the medicine and the surgery services or something like that. It's a fairly constant thing. Disparaging remarks about patients, not in front of patients, but about them. Presentation with advanced disease, the patients that did not have access to good care present with late disease. Fragmented care, too many teams taking care of the patient. Nobody really knows who owns the patient. The patient's family doesn't know who's in charge. The doctors don't know who is in charge. And that sense of confusion was distressing. Poor communication, and then again, any kind of disrespect. Some of these things really didn't cause a lot of distress. Actually, bad-mouthing didn't even cause mild distress. And I think it was interesting that this is something that we tell people you shouldn't do. We need to treat each other with respect. And I think after a while it does become demoralizing, but I think it has become such a part of our culture that people don't even, they say, yeah, it happens, but don't register any kind of response to it. Most distressing, again, advanced disease presentation. Patients who are uninsured and present with basically tertiary presentation of primary disease. Unprofessional behavior of superiors, again, disrespect to patients and team members. Futility of care, this showed up. It didn't happen as frequently, but when it did happen, it was distressing to students. When we looked at residents' response, the futility happened more frequently. I think they're more frequently involved in intensive care settings and more directly responsible for this, so it was a larger factor in the resident cohort. Discrimination, and then non-disclosure or poor disclosure of error. Again, these things that you hope wouldn't happen at your medical center and don't happen very frequently, but when they do, they just don't sit well. And again, we're dealing with a cohort of learners that don't have a way of dealing with it or don't feel comfortable saying, well, shouldn't you have told the truth? So we were very interested then in knowing, so we documented that these situations that occur in the healthcare setting were causing some distress for our students, and wanted to know if the relationship between burnout that was so well documented in nursing was also happening with our medical students. And we co-administered then a NASDAQ burnout inventory for the health science professionals starting in April, May of 2009. The study group, again, 3rd and 4th year students and residents in the core specialties. We limited it to the core specialties that the students were doing their major clerkships in. The idea was that they were seeing basically the same learning environment, that the residents in medicine, surgery, peds, and so on were seeing the same environment as the students, and we were really interested in the differences to their responses to different situations. First with burnout, what we found was that the residents and students did, their burnout scores were relatively high. For residents, now the burnout scale for people who haven't taken it or used it measures 3 domains. One is emotional exhaustion, The other is depersonalization, and the third is personal accomplishment. The way that it was originally intended to be used was just to look at these elements separately. I think there are some papers that have combined them in different formulas and used different kinds of criteria for determining who's burnt out. But we used the scale separately. Our house staff were greater than 50%, were rated high on the burnout scale for depersonalization, and nearly close to half of our residents rated high in emotional exhaustion. Medical students were significantly lower in depersonalization, but pretty close in emotional exhaustion. And I mentioned this yesterday, that personal accomplishment was actually high in both groups. And that's an interesting thing, and I think apparently different in the nursing literature. But despite these episodes, even people who registered high in depersonalization and emotional exhaustion somehow were able to maintain a sense of personal accomplishment, which may be kind of unique, and we can speculate what some of the reasons for that might be. When we looked at residents and tried to correlate frequency of distress, intensity of distress against the different domains of burnout, we found positive relationships in all three areas for frequency of distress. So these were significantly positive: depersonalization, emotional exhaustion, and personal accomplishment. For intensity of distress, it was significantly positive in depersonalization, emotional exhaustion, but not significant for personal accomplishment. So we did see these positive relationships. Medical students, similar, although again, I mentioned this yesterday, the frequency didn't seem to affect, nothing seemed to affect their sense of personal accomplishment. Again, I don't know, maybe medical students are far enough removed from the immediacy of this decision-making and involvement that it didn't kind of affect their sense of what they're doing. One unusual finding that we really haven't been able to explain is that there was actually a significant negative correlation between intensity of distress and depersonalization. And it's hard for me to try and put that together, why that would be negative relationship, and why it would be different for medical students than for residents. And again, that's something that we thought about, that maybe that the intensity of distress is somehow having this reaction that students are feeling more empathic to their patients who are at the center of all of this. It's just speculation, and we can't really figure that one out. So we did find this relationship, and it's a correlation. And I think, as we know in observational cross-sectional studies like this, correlation does not mean cause and effect. You know that the two things are related to each other in either a positive or negative way, but you can't say for sure that one leads to the other. And so we were kind of interested, does moral distress really lead to burnout? And how could we test that? And we got some suggestions from a few people who looked at the data. And again, this was our hypothesis that moral distress leads to burnout. We administered the burnout scale to third-year students and PGY1 residents, so brand new people coming into the system. They may be burned out from what they were doing before. We don't know, but this is in July of that year. And then we co-administered again the burnout survey and the moral distress survey to all students and residents in April 2010. So what we wanted to look at was the change in burnout and to see if increasing levels of moral distress were correlated with an increase in burnout. So that would get us closer to a cause and effect. It doesn't, I think, exactly prove it. But again, if we saw that higher moral distress measures led to a greater change in burnout, I think we thought that would get us closer to cause and effect. However, we didn't find that. There didn't seem to be a relationship between the change in burnout and the degree of moral distress, either frequency or intensity. And we are still analyzing this data, but that relationship, we're sure that that does not exist based on, again, the data set that we have from last year. The relationships between moral distress and the absolute levels of burnout did persist, though. So it wasn't the change in burnout that was important. It was where your burnout level was. So if you were high in burnout, the correlation between that and moral distress persisted, it didn't really matter as much where you started. So again, we are just working with this data. We're repeating this year and hoping to see if this is reproduced. And again, as I mentioned before, we saw this same general pattern, the strong relationship between the frequency with which somebody registers the episodes of moral distress and the intensity with which they feel the distress. So trying again to figure all of this out, how to put it together, and what's causing what and what the relationships are. So if we can't say for sure that moral distress causes burnout, our data doesn't support that at this point. Does burnout lead to moral distress? We would think not, because burnout is more of a reaction to a chronic workplace environment, and that it wouldn't be going in that direction because the moral distress does describe the workplace environment. But I don't think we can say for sure that our data excludes that possibility. On the other hand, could it be that that there is some underlying phenomenon that has to do with the work environment and an individual person's reaction to that work environment that could lead both to burnout and moral distress? That's another possibility, that there's something going on beneath. And again, I think gets a little closer at explaining the individual variation that we see. Or is there some overlap between moral distress? I'm tossing this out as an idea, and there may be reasons why it could be true, reasons why it wouldn't be true. But another possibility is when we are measuring moral distress and measuring burnout, it's maybe different expressions, again, of something underlying this relationship between the individual and the work environment. So what do we do about this? The next question, we know that this is happening. We know that people are burnt out. We know that people are experiencing moral distress because they are seeing things that they believe to the core of themselves, that this isn't the way we're supposed to behave, or this isn't the way things are supposed to happen. What can we do about it? And I think before we can answer that or talk about it, I want to go back and talk about, again, the nature of the moral contact with patients in the 21st century. This is a wonderful paper by Edmund Pellegrino, one of the fathers, I think, of American biomedical ethics, where he talks about the nature or moral understanding of the medical profession, and sort of builds the very logical case for the fact that medicine is a moral profession. That what we have is the doctor who has acquired skills and knowledge and expertise and gone through a lot of training for the purpose of helping patients. And you have a patient who is generally sick, not always, and wants to be helped. But inherent in this relationship is the power imbalance. The doctor is knowledgeable, and there's strength in knowledge and strength in the expertise. The patient doesn't have the knowledge and the expertise and is vulnerable because, as Pellegrino says, it's experiencing impaired humanity. Threatened, I think, as Eric Cassell would say, by the loss of integration, loss of integrity by the illness. And so the patients are in a very, very vulnerable position. And the patient, again, doesn't have the knowledge that the doctor has and has to believe and trust that everything the doctor is doing and recommending is in that patient's best interest. And that really establishes the fact of knowledge and expertise, the fact of impaired humanity, the relationship between the two establishes the moral nature of the relationship. And he describes the act of medicine as when these two separate moral agents come together to decide on the right course for that patient at that time. But this is, of course, complicated. Nothing is as easy as it seems, because we bring into this relationship all of our past. Everything that we've learned, our education, our family, our economic, socioeconomic concerns, our religion, values, beliefs. And the patient comes in with the same influences, the same thing that the patient has and the doctor has, but they may not be the same, and most often they're not exactly the same. And more in the future, we can be guaranteed that we're going to see lots of patients who don't necessarily kind of match us. Pellegrino says at some point in the future, maybe you should kind of hang out a shingle on your shingle, say, this is my religion, this is what I believe, and we'll do this, won't do that. But I think that would be pretty sad. As healthcare providers, we all felt that we could only take care of patients that were just like us. And I think that one of the great challenges of being a provider is figuring out how to cross those, or bridge those gaps. Well, is this really what's going on these days? You've got the nice doctor-patient relationship. And even though it's complicated, I'm questioning, like, how often is this really the case that the relationship is just between the doctor and the patient? We know that there's a team, and a lot of the things that caused our students moral distress and our residents moral distress was sort of not getting along with members of the team, or the team's not being necessarily aligned, team members not being aligned with each other, and not necessarily aligned with the patient. And it's one of our mantras these days, that medicine is a team sport, or healthcare is a team sport, and that I know this is an interprofessional audience, and we're all part of the same team. So it's not just the doctor-patient relationship. Very, very infrequently, even in a clinical outpatient setting, when it's one person in an examining room with one patient, we all have the system and the team behind us. And even more than that, there is a system. A very complicated healthcare system that either enables or constrains our actions as providers. And we are really not alone either in our abilities or our decision-making capacities about what we can do in different situations. And so in some ways, I hate to say it, but the notion of the doctor-patient dyad seems a little bit quaint and sort of nostalgic. That wouldn't it be nice to go back to the days of Luke Fields when it is the doctor looking intently at the patient. But that's really, I don't think, the world that we live in. So this is a problem in some ways, because this is how we think of the system, and that is a cartoon of Mr. Hyde. Dr. Jekyll and Mr. Hyde, this is Mr. Hyde. We think of the system as this kind of monster, and the system itself is what caused a lot of moral distress. Even if you look at breakdown in communication, that's a systems issue. If you look at even not being able to do anything about unprofessional behavior on the part of supervisors, that really is a systems issue as well, because we should have safe ways for all learners and all members of the team to be able to interact with anybody on the team and say, hey, did you just hear what you said? Did you just see what you did? Isn't there, or some way of getting that across, or reporting it anonymously? But our systems like that should exist. Not only that, I think sometimes we think of ourselves, and I think Dr. here, it could be any provider, as the superhero that's fighting the system. And the system is the bad guy, and we're the heroes, and you do all these workarounds to get, to fool the system, and it makes you feel great, and you go home at night and say, I was so smart because I was able to work the system to get it to work for my patient. But I think it's one of the kind of dictums of the Toyota model, and we can't praise the Toyota model as much as we used to be able to. But that workarounds, you can do it once. But a workaround means that there's something wrong with the system. And if you do the same workaround over and over again, you're really not doing the correct thing. What you need to do is fix the system. What we know about a system, it actually is people, process, and technology that are used in combination to achieve a specific goal. You don't have a system without people, and systems are created by people. And this, I think Don Berwick uses this quote quite a bit with the Institute for Healthcare Improvement. Every system is perfectly designed to achieve the result it gets. And you get the product that your system is put together for. And I think it's actually, was originally said by John Deming, who was one of the pioneers in systems engineering in the 20th century. So, this comes from a great paper that I highly recommend to everyone. Lancet Commission and December 4th issue of Lancet about the need for reform in medical education across the globe. But healthcare providers now are in the human face of the healthcare system. You see that they should theoretically be aligned, and so we have our pogo moment. And I think there are probably a lot of people in this audience that are too young to remember when this very, very famous cartoon came out around the time of the Vietnam War in 1971. We have met the enemy, and he is us. And so this notion of us against the system is, I think, something that we really have to think about. Is that really the correct moral response to the distress that we feel? So again, getting back to what Marcia said at the beginning, is moral distress always a bad thing, or can we look at it as warning flags that alert us to something that we have a responsibility to try and fix or improve or figure out some better way of doing this? So what do we do? What are our moral obligations in dealing with moral distress? Resilience or retreat. When we talk about the importance of maintaining personal well-being, and we have physicians' wellness committees at Vanderbilt now and a very, very active student wellness program because we want to build resilience, because we know that people burn out. We know this is difficult work. We know that it's tiring and emotionally draining, and we have to think about our own well-being. We know that storytelling helps a lot. That when we were in the small groups, and we still actually, all of our students now meet with master clinical teachers every 6 weeks to take over this function of the last Tuesday sessions. But that narrative, the storytelling, allows people to assign meaning to their experience. That's what storytelling is. It's always revisionist, but that's fine. That's what you have to do, and that's one of the great strengths of storytelling. Debriefing, processing. What could we have done differently? Why did it happen this way? Some of the things that cause moral distress are just not going to go away, and some of them aren't bad. They're just the result of value clashes, that this family wants the mother to stay on the ventilator indefinitely because I believe that this woman, my mother, is still alive. You can't, quote, pull the plug. We don't agree with that, but we respect the autonomy and the dignity of the people making that decision. We feel distressed, but it's that those kinds of value clashes are not going to go away, but it does help to debrief and to talk about them, and again, the value of discussion. But this could either be resilience building, or it could be retreat. If that's all you do, is like just kind of worried about myself, and how do I take care of myself, and how do I get through this? And I think we talked a little bit about massage therapy yesterday, and massages are wonderful, but and we do want to worry about personal well-being, but is that enough? So beyond resilience, we really have to think about refining our systems to allow all individuals in the team to participate in improvement. So we have to have systems that allow for their own improvement. That's kind of built into how the systems work. And we're a long, long ways from that. And we have to empower our workers with permission. They are allowed to be part of that improvement process. and the skills to do that diplomatically, because we really don't want students or residents or anybody in the healthcare delivery team to self-destruct. That is not a morally correct thing. To tell the students just speak up to, the kind of fierce attending, it's not right. That's not what we really want. Kind of paraphrasing from the Lancet as well, and some thoughts I think of David Irby and Molly Cook in the new Flexen Report, Educating Physicians, that came out last year. But the new professionalism really encompasses responsibility for the ongoing refinement and creation of moral systems of care. Huge, huge task. There's no magic wand. I wish there was, that we could wave and make it that way immediately. This is very difficult, ongoing work, full of constraints, some of which we have absolutely no control over. But how do you create the most moral systems within the constraints you have to live with? And again, from the last commission, we regard transformative learning as the highest of three successive levels. Informative learning is about building experts, knowledge and skills. Formative learning is about socializing students around values. Its purpose is to produce professionals. And I think we've been trying very hard at building experts and creating professionals. But transformative learning is about developing leadership attributes, and its purpose is to produce enlightened change agents. And I think that as institutions of healthcare learning, medical learning, nursing learning, that's what we have to aim for, is transformative learning, where people really see part of their role as bringing about needed change to make systems better. So I thank you. I love the old Apple and the Mac user now, but to think different. I think we all will need to think different in the future, and that is our challenge. So thank you very much.
Thank you, Dr. Miller, for your thoughtful discussion on the issue of moral distress in medical trainees. As a fourth-year medical student and member of the School of Medicine Student Advocacy Committee, which hears reports of mistreatment of trainees directly from the students themselves, I have both witnessed and at times experienced the effects that moral distress has on medical trainees. The clinical learning environment here at the University of Virginia is generally very constructive and nurturing. But many students realize that their preclinical expectations about third and fourth year rotations and the practice of medicine are unrealistic, even as they find satisfaction in caring directly for patients and their families and start to feel like they're finally doing what they came to medical school to do. The process of reorienting these students' expectations in the final 2 years of medical school can be demoralizing and distressing. I would like to focus on three specific areas that I and my student colleagues have found to be particularly challenging. First of all, as Dr. Miller has mentioned, we're challenged by the healthcare system failures that become apparent to us when we become involved in patient care. The relative proximity of the medical student's perspective to that of the patient makes us especially sensitive to communication failures, accessibility problems, and social service issues that are frustrating to our patients. We're forced to confront the fact that the system simply doesn't always work the way that it should to provide optimal patient care. As Dr. Miller's study of Vanderbilt medical students indicates, students do experience distress when the attending physician or resident answers a patient's questions inadequately or simply ignores them. Optimal care is not provided to our patients because of language barriers or stigmatizing social circumstances. Poor communication among multiple teams that are collaborating in the care of our patients negatively affects their care. A patient presents with advanced disease because he or she faced barriers to accessing care. Or a patient is discharged before we think it is safe because no one is at home to care for the patient. We ask ourselves, within the constraints of this system, can I make a difference at all? Second, there's the hierarchy of the team structure on the wards. This is necessary for instruction and for patient care and benefits students in many ways. but it's challenging to feel that you're always trying to improve yourself, always trying to impress your upper levels, and to realize that you're no longer at liberty to always follow your own moral compass. The survey of Vanderbilt medical students addresses this issue in items such as, a member of my team was disrespectful to someone below him or herself on the team ranking, and the team went along with treatment we did not believe was indicated because an attending physician insisted on it. We find ourselves as students asking, am I good enough to do this? And does what I think really matter? Finally, many students fail to perceive the extent of the personal sacrifice that will be required of them when they assume responsibility for the care of their patients. They find that their time is no longer their own and become discouraged when they cannot keep personal commitments. They're also bothered by the fact that this affects the way they relate to and care for their patients. It is demoralizing to feel that suboptimal care is provided to a patient because the team is tired and overworked. Even students who find themselves feeling truly at home practicing clinical medicine can't help noticing the sacrifices that they make to serve their patients, and occasionally find themselves asking, is all of this really worth it? My own feeling is that moral distress in medical students, if it is not appropriately addressed, can have negative consequences, both for practitioners in training and for their future patients. It's become very important for me personally to provide honest, transparent, and realistic answers to underclassmen who ask me about the challenges that I've faced on rotations. Recognizing the difficulties that students confront when they begin working on the wards, and providing a safe outlet for those students to discuss their concerns, as Dr. Miller and her team have done with their last Tuesday's meetings, have the potential to mitigate emotional exhaustion and the other negative consequences of moral distress, while encouraging a positive response to morally distressing situations. After all, when defined as negative emotions that arise when one knows the morally correct response to a situation, but cannot take action because of systemic constraints, moral distress can be a good thing, in that it implies that an individual is able to recognize both the morally correct thing to do and the systemic constraint that prevents him or her from taking action. This awareness under the right circumstances can be motivating, challenging student doctors to improve the system in which they work to better serve their patients. From this perspective, as long as I'm practicing in an imperfect healthcare delivery system, which I expect will be a long time, I actually hope to experience moral distress simply because some situations are rightfully distressing, and my negative emotional response to those situations is a reminder of my own humanity and my sensitivity to the needs of my patients. Once again, I would like to thank Dr. Miller for sharing her perspective on an issue that is important to me. And I would like to express my own gratitude as well to the mentors I have encountered during my time as a student here at UVA, who have exemplified patient-centered care, sound moral judgment, and professionalism, even in distressing situations. Thank you.
That was wonderful, Anne. Thank you, and thank you for this opportunity to respond to Dr. Miller's excellent presentation. I began to get interested in moral distress almost 20 years ago because of nurses' stories. After I would give talks, nurses would come and say they needed to just ask me something, and they would proceed to sketch out a narrative so vivid and so detailed that I thought it must have happened to them yesterday, and in fact it happened 20 years ago. So there is something extraordinarily powerful about this phenomenon. The more I study it, the more convinced I am that it is an interprofessional phenomenon. In fact, it isn't limited to the healthcare professions. One of the liveliest conversations I ever had about moral distress was with engineering students. So the issues of what are we going to do about this, and how can we help each other with this, and how are we studying this are very prescient issues. And I agree with Dr. Miller that there are ways in which the cultures and the systems within which we give care are extraordinarily important to pay attention to if we're going to do anything about moral distress. Let me give you a couple of just reflections based on the presentations that you've heard so far. In my own research, one of the things, I do study physicians and nurses. I do find that physicians and nurses really share a view of what are the most troubling situations. They center around futility issues, aggressive care in the face of futility. They center around poor team communication that compromises care. the issue of no one making a decision and care going on and on without any intervention. So we have ways that we can help each other if we begin to talk about this and grab hold of this. I wish that I felt more positively about the benefit of moral distress. In my own research, I continue to see the extraordinarily negative consequences of moral distress if unaddressed and allowed to perpetuate in systems. A colleague of mine who's actually in the room, Beth Epstein, and I have written a paper on the interaction between moral distress and moral residue crescendo over time. And what we see is that over time, repeated situations of moral distress that are not adequately dealt with leave a residue in providers, and that residue itself begins to grow. And we begin to see a number of very distressing responses to it. So while I think one of the things that's so useful about a session such as this and so important for us to think about in education of health professionals is how do we begin to help the initial experiences of moral distress be talked about, be discussed, be empowering people to say there is something you can do about this. My own most recent work is discouraging in this regard. Those of you who will be at the presidential inauguration, you will see our poster that we submitted for that on moral distress in physicians and nurses, and 49% of the nurses have thought about leaving or have left a position in the past because of moral distress, and 21% are thinking of leaving now. For physicians, 19% had thought about leaving because of moral distress. We only have one other study that looks at this that I did with Leslie Blackhall, and it was 2%, so this is a significant difference. And 11% are thinking about leaving now. Now, obviously, this is something that we have to really pay attention to. I haven't directly studied burnout because I'm much more interested in this issue of intention to leave. And there are data, we have a lot more data about burnout. My view is that moral distress is a very pernicious and hidden element of burnout, that it is not contiguous with burnout, but it may actually be a powerful piece of burnout for those people experiencing it. So this issue of how do we begin to discuss moral distress, how do we begin to intervene with it, how do we begin to work together in the hierarchies of teams to be able to ameliorate this is critically important. I also agree very strongly with Dr. Miller that there are three what I call root causes of moral distress. The root causes are clinical situations. They are factors internal to the caregiver. And one of the most powerful of those is a perception that you're powerless and you can't do anything about it. And so this notion of how we deal with that is critically important. The third major area of root cause is external factors in the situation. And we are beginning to learn more and more about those factors and how they impinge on a person's moral integrity. This is the reason to me that it's difficult for me to say moral distress is a positive phenomenon, because it does represent a threat to one's moral integrity. And the truth is we are engaged in a profoundly moral practice, all of us in the health professions. And we cannot afford to feel that our own moral integrity is being threatened in the processes of giving care. I would just end with a wonderful thought from William Bartholomew. Bill Bartholomew was a pediatrician, known to many of us as a superb ethicist. He died a number of years ago, but one of the last things he did was participate in a lively discussion about moral distress on an ethics website that I was part of. And he said one mark of moral progress in a community may well be the extent to which the members of that community deal with moral distress. I would say all the members of the community. Thank you.
Thank all three of you for your presentations, and we have a few minutes for our community to weigh in. Do we have comments, questions from those of you in attendance? Okay, I'm going to come around with the mic. And please tell us who you are.
My name is Jay. I'm a student nurse. And my question is for Dr. Miller. And when you were talking about creating a system or refining the system to allow for and promote personal well-being, I was curious what that may look like, if you have some examples, perhaps?
So as I understand the question,
Make sure I heard it right. Some examples of how we can permit all members of the system be involved in the system's improvement. I think some of those things do exist in our quality improvement efforts now. In root cause analyses of sentinel events that are multifactorial, we have tried to get our students and residents involved in those processes in one way or another. I think a lot of systems, and Vanderbilt has anonymous sort of drop boxes for comments or things to be reported by anybody, by patients, families, students, nursing staff, when they see things that are questionable, that we encourage reporting in a very anonymous fashion. I think blogs, some of the social networking technology, again, there are other ways of getting feedback to the system and having a system that actually makes these methods accessible and encourages people to use them. It's a start. I think in education, one of the things that we're trying to do with students and residents is make sure that part of the core knowledge and core curriculum is built around certainly professionalism and interpersonal communication, but also a very deep understanding of both microsystems and macro systems, so that they have some knowledge and some skill in deconstructing what's happening in clinical situations and being able to attack it that way.
Tell us who you are.
Hi, I'm Lindsay Weeby, retired faculty. I'm interested in the, is it frequency and severity line that you show the linear relationship with some at the bottom and some at the top. So I'm interpreting this to mean that moral distress is a relative phenomenon. There's no absolute moral distress situation. So are those, I don't know whether, can you identify the people who somehow can function in a system and not be terribly upset by these things that go on? You know, maybe we're selecting the wrong people to be in tough situations.
And I think I really resonate with what Ann said about, you know, again, and I would say that moral distress, the experience of it is negative, and sort of feel it is a negative thing, but the fact that you still have the moral sensitivity to recognize these things, I think, is a good thing. And I think that as compassionate, empathic healthcare providers, that moral sensitivity is critical. And so I do worry about the people in the bottom left-hand corner. Is there something missing in that group? Because there are troubling things that happen. We know that. We know the system is not anywhere quite perfect. And I think that a certain amount of moral distress is not a good thing. And that, again, we don't want it to happen because it can have devastating effects over a period of time. But it is a sign that we're still alive and say, you know, and recognizing our own humanity. And so I do worry about that group. Since these are all anonymous surveys, we, as our little research group, our study group, try to say, how can we get those people? How can we figure out who they are and get them in a room and give them, you know, do focus groups and say, what aren't you seeing? But I don't know how we'd be able to do that.
We see the same significant variability in practicing clinicians. So that while physicians generally have lower moral distress scores than nurses, some physicians have considerably higher moral distress scores than some nurses. We see three patterns so far in the literature. One of them is basically an explanation for these people at the bottom, which is that they become so acclimated and accustomed and desensitized to the environment that they just don't see that there's a moral problem at all. We also see people who leave people who leave. We also see people who conscientiously object. So those are the only three patterns we see so far. None of them are terrifically positive, although at least the conscientious objectors are speaking up and saying, but sometimes this takes the form of nurses refusing to take care of a particular patient or refusing to work with a particular doctor. So it isn't to a positive purpose in terms of system change.
Well, it's with distress that I say our time has elapsed. But I think a wonderful conversation that has been started by this wonderful group of speakers and continued by you, and I hope continued in your work today and subsequent days. Please join us next week when Dr. Tony Bach from the Seattle Cancer Care Alliance at the University of Washington will be with us, talking about difficult conversations, compassionate care. This will be jointly sponsored with the Nursing School's Compassionate Care Lecture Series. Please give a hand to Bonnie Miller and Bowman.